Hello, we are Group 7, and my group members are Buntan Nath, Anjay Villamil, Vinny Gonzalez, and me, Justin Corpuz. And we are presenting on occupational health with our policy being HR 1195, which was passed in 2021. To put in perspective, since 2011, issues regarding occupational health within the United States has notably risen in the number of workplace violence incidents. According to the U.S. Bureau of Labor Statistics, they identified in 2018 that 73% of non-fatal violent events involve healthcare workers. With that in mind, compared to any other occupation, healthcare workers are 5 times more likely to be injured due to violent acts within their workplace. Consequences that arise from this is anxiety, depression, and increased stress, leading to severe increase in rates of absenteeism and burnout, which may result in these healthcare workers to lower their productivity and retention levels. This diagram highlights the significant differences between healthcare and social workers in regards to intentional work injuries. In particular, the number of reported incidents involving healthcare or social service workers showed the rates of violences have increased faster than any other occupations. To be exact, there is a 7.2 difference between the rates of intentional worker injuries in relation to healthcare or social workers compared to all private industries. Our policy solution is an independent federal legislation that was passed in 2021 called HR 1195, or also referred to as Workplace Violence Prevention for Healthcare and Social Service Workers Act. This policy is designed with the intention to standardize the nation's guidelines on preventing violence incidences for those who work in a healthcare or social service role. In addition, this standalone policy requires a new standard that must adhere to Occupational Safety and Health Administration policies, or also known as OSHA. This new standard is composed of employers being required to produce, administer, and sustain a violence prevention plan. And these policies must be able to pass OSHA inspection guidelines before being implemented to test its effectiveness.
In the past couple of years, several federal and state level policies have been introduced in an attempt to decrease workplace violence throughout healthcare settings. HR 7961, or the SAVE Act, is a federal policy introduced in the House in June of 2022. If passed, the bill will criminalize assault and intimidation of working hospital employees, as well as authorize grants to help in the funding of reducing hospital violence. HB 5682 is a state-level policy in Michigan that was introduced in the House in January of 2022. If passed, the bill will enhance penalties for assaulting emergency room staff by creating a new misdemeanor charge that is punishable with 93 days in jail and $1,000 in fines. HB 4142 is also a state-level policy in Oregon that was introduced in the House in February of 2022. If passed, the bill, similar to Michigan, will enhance penalties for severe violence towards healthcare workers with a minimum of a 5-year sentence or $125,000 in fines. Looking at the more recent landscape of policies for workplace violence in healthcare settings, it is evident that there is an issue needing to be addressed. Recently, there has been a resurgence of retaliation towards healthcare workers due to the anti-vax movement gaining more traction after the COVID-19 pandemic. Despite this resurgence, HR 1195 and other related policies have pretty strong public support, along with bipartisan support, because the protection of healthcare workers is popular and essential to the public.
For our logic model, we decided to focus on employers and staff training. For staff training, resources include documentation for a new training program and funding for already trained personnel who will be in charge of conducting staff training. This will lead into staff being trained on the new procedures, such as actions to take during high-risk situations and preventative measures. The output will be a record of compliance from all staff in the form of OSHA standardized documents, which are renewed annually. The second input are the employers who are required for the composition and documentation of new policies. They will also be in charge of ensuring that those documents are stored according to already established OSHA guidelines and are available to view as far back as 5 years. For the activity, they will view current guidelines on violence prevention and modify them or draft completely new ones if there are none currently active. This will result in the output of a new safety standard that reflects OSHA requirements outlined in the policy, as well as an annual incident report that is filed with the U.S. Bureau of Labor Statistics. Both of these will lead into the same outcomes. For the short-term outcomes, HR 1195 will directly result in having more healthcare and social workers be consistently prepared on how to prevent workplace violence. For intermediate outcomes, this will result in reduced violence against these workers and an increased ability to avoid high stress or dangerous situations. The impact of this will be increased employee well-being, a lower burnout rate, less errors during work, and an increase in job retention.
For questions regarding our evaluation, we have included the following, which address each level of outcomes as shown in the logic model. For our short-term outcome, our question is, did HR 1195 increase employee readiness in terms of workplace de-escalation and individual safety? For our intermediate outcome, we have, did HR 1195 decrease incident rates of violence in the workplace? And for our final long-term impact, we have, did HR 1195 increase employee retention rates? Each question is used to assess if our policy is being implemented effectively and making the change it is supposed to.
For our evaluation design, we determined that it would measure an intermediate outcome. We would use a quasi-experimental and interrupted time series design as there would be no control group to compare data to, as the bill would apply to all hospitals and would be unfair for other hospitals to have a lack of violence protective programs in place. Data would be collected from OSHA's and the U.S. Bureau of Labor Statistics publicly available annual reports on incidents in workplaces. Each hospital would be recorded as well as its number of incidents of workplace violence and outcomes of investigations. The time frame of this evaluation design would be 3 years before and after the bill was passed, in which we would compare the incidence rates in different hospitals. Some evaluation challenges that we may face are the underreporting of cases of workplace violence. This may be due to apprehensive attitudes when reporting cases, as it may introduce feelings of anxiety and fear of retribution. Others may not want to report incidents as to protect others. It is also difficult to determine if changes in workplace violence rates are due to policy implementation, as a statistic reported by OSHA also covers workplace accidents. Unforeseen changes in hospital staffing and cuts in funding may also skew data. A cut in staffing or an increase in untrained workers may confound data by introducing more incidents of violence, as there would be a surplus of untrained staff. Impacts on health equity may include a decrease in health disparities by protecting workers from racial violence, by preventing escalation of tensions, and through the usage of protective measures through practices taught by workplace violence prevention programs. The bill can also decrease health disparities by protecting workers' mental health and well-being. Violence protection practices would prevent workers from encountering high-risk and stressful situations. Lastly, the bill may also increase health disparities as it would redirect funding, in particular for hospitals in rural areas, as it constrains scarce resources that would normally be dedicated to patient care.
For our open-ended question, we wanted to ask the class, what are some potential downstream effects of this policy to both patients and healthcare providers, aside from the decreased violence?
Last but not least, this is our reference slide, and thank you for listening to our presentation.